So the response has a standard criteria that we've been using for years, and actually it's either using the ELN or the LWG-MRT criteria, where we have what I simplified to say control of the counts and no significant splenomegaly, control of the symptoms. Of course, it should be complete control of the symptoms, but I can easily say that none of the drugs is a magic, and people will have some symptoms, and lack of adverse events or actually the consequences, which are the vascular, thrombotic, or arterial. Of course, there are certain circumstances where people have unprovoked events after surgeries or some other exposures, which should not be basically counted as a disease related or a medicine failure, but this has to be all taken in the context. So control of counts primarily, there is of course a debate about how low the platelets should be, how the red cells need to be, but there is definitely a general consensus and a recommendation to keep hematocrit below 45%, and then the response does require lack of phlebotomies. So patients need to have a normal counts without phlebotomies. That's considered a complete hematologic response. And then changing the therapies based on that, it's also actually dependent. Of course, if somebody has a breakthrough vascular event, that's a to-go, because that apparently looks like the treatment failed. Of course, if that was in a situation where patient was off therapies for some reasons, or was undertreated for some reasons, or could not just get the dose ramp up because of side effects, that has to be all considered, whether there was a real failure or it was just under treatment. And then uncontrolled counts is a little bit questionable. Of course, somebody has increased white cells and permanently requiring phlebotomies every month is not a control with the available therapies that's there. So that one definitely deserves a switch in. I would say phlebotomies 3-4 times a year could be acceptable in certain situations. Of course, we all like it with the complete response without any phlebotomies, but sometimes we just have to compromise, and if patients just cannot tolerate higher drugs, we can say how you can have 1 or 2 phlebotomies, I don't really mind, providing everything else is being nicely controlled. So that's something to look at, and definitely being aware of the warning side, right? Rising white cells, persistent and controlled red cells, symptoms, they are significantly burdening and really stay with the patients with poor quality of life, even despite being controlled counts, because sometimes it does happen that patient has normal counts but is significantly symptomatic. And at that level, we sometimes even doubt, is it a medication intolerance? Is it the side effects profile? Is it just the disease burden? What's going on? In that situation, definitely keep an eye to see whether the disease has progressed to myelofibrosis, which comes with increased symptom burden. But in that level, assessing the spleen size to see whether there's any immature hematopoietic cells out there. Of course, repeating bone marrow based on consideration whether there is more fibrosis, more clonal evolution, and looking at the blast percentage. Those are standard assessments that somebody should be basically be on a lookout for all the time. I would say any patient that's failed frontline therapy should be assessed by MPN experts on somebody who's seen that, because it's not rare we have patients that are just being not really properly dosed. They just need a little twist and will just do perfectly fine on the same agent. They just need a determination, are we progressing? Are we having just insufficient therapies? Are there any comorbidities? So those I would definitely at least consult online or reach out, send them to referral centers. Maybe, a lot is just one consultation where the patient just needs to be seen and assessed and make sure, yeah, they are doing right, no worries, particularly if they are younger, because we have a lot of PV patients, they are young.